So, for start, I would like wake up, of course, and I would like said about very difficult pathology of a very difficult high-grade AVM, and this AVM impossible to treat with radiosurgery, with open surgery, and this not good for treatment of transarterial endovascular approach. So for start, I'd like said about my technique. Last 15 years, so first treatment of transvenous approach, I started in 1999. Last 15 years, I work without supporting device, without balloon, without coil, and very simple, but I think simple is genius. So what is my technique? All know this reclam about Onyx is not adhesive liquid embolic agent for treatment of AVM. We know Onyx is adhesive agent. And this property became a useful on in my technique, which eliminated the need for supporting device, balloon, coil, and double catheter. We know many catheter in treatment AVM is not very good, but all catheter have 3 markers. In situation, we work with 4 catheters, 12 markers. It's very difficult for embolization. So I would like show this simple technique. We know the volume of embolic agent in the catheter in 0.70 milliliter. I push this quantity of embolic material and stop and wait at head, catheter and embolic material. This is schematic embolization, and you can see after occlusion of parent vessel, embolic material go retrogradely, and same with balloon. Close of parent vessel. I wait 3-5 minutes, retrogradely, we close of artery, and expecting time 15-20 minutes, and embolic material go anterograd. Without balloon, without coil, and this is technique, it's very simple and very effective. This is schematic, but why is transarterial approach not very good? Only transarterial embolization without transvenous one way lead to occlusion of normal vessel and possible ischemic complication. Why is the transvenous approach preferred? So this is same picture, only transvenous approach. I wait at heading of catheter and embolic material. I close of vein. Embolic material never don't go retrogradely in this situation, but it's need only time. And after pathological vein drains only, pathological vein drains only pathological vessels. Occlusion of pathological vessels only possible. What is working really? You can see catheter in transvenous with transvenous approach. I push small quantity of embolic material and wait, expected time 2 minutes, and material go return. This is not problem, it's very good for me. And close of vein. And after, I wait 4 minutes, and last is 15 minutes. After, material go anterogradly. And this same with coil, with balloon, and we don't need a supporting device for this. And material in close of nidus. I would like show a new material. This is HELP material, Hudak embolic liquid polymer. My science is 25 years. This is material with disappear of contrast material from embolic material. And you can see after embolization, the next day, contrast material absolutely disappear from embolic material. So this is a result of treatment. And the first case is 46-year-old male with spontaneous ventricular hemorrhage. In satisfactory condition without focal symptom, headache, nausea, vomiting. This is AVM, deep AVM, and not good for catheterization of all branches of this AVM. Lateral view of vertebro-basilar system in API, and you can see many feeder. It's impossible to catheterize it, all feeder and embolization. So is draining venous system is basal vein and superior petrosal sinus. And transvenous approach is narrow show of catheterization of venous system, transarterial and transvenous approach. Is combined arteriovenous approach. And you can see result after one procedure. And I would like said, I never not propose only transvenous approach. But this is danger for rupture. I propose only combined arteriovenous approach. Interesting, vessels originally visualized needle anomalies mustn't be always occluded, resected, or irradiated because they are capable of regeneration and normalization. And now about complication. So possible hemorrhagic complication, intraoperative, perioperative, postoperative. So intraoperative is guide wire microcatheter vessel perforation, embolic material extravasation, vascular dissection, rapid hemodynamic changing, most dangerous for and unpredictable. Sharp increasing of blood pressure. It's perioperative and postoperative intranidal aneurysm rupture and possible epileptic seizure with high pressure. Ischemic complications is arterial venous retrograde embolization, transnidal embolic material spreading in the normal arterial system, catheter rupture during injection of embolic material, embolization of normal vein. The first case, this is complication. This is 31-year-old female, young woman with intraventricular and intracerebral hemorrhage. CT angio show deep thalamic AVM. This is 3D reconstruction and combine a transarterial transvenous approach. It's March 3, CAVA approach, one procedure. The patient woke up without problem. March 3 in 9:40 rebleeding. Decompressive craniotomy, ventricular drainage. March 6, situation is worsened. You see a very terrible big edema. 9, situation terrible. March 21, you see this worsening of this situation, and March 23, MRI, dilated of pupils, bradycardia, and hypotension. So this is situation terrible, young woman. We did not expect that the patient will live until morning because of the death of the brain. In the morning, we will stop the ventilation of the lungs. The next day, I arrive in clinic. Our patient condition is improved, stabilized, pupils narrowed. 1 month later, ventriculoperitoneal shunt, operation was done. The patient condition improved. 3 months later, patient underwent cranioplasty. March 30 angiography, malformation is done. So this is control angiography and MRI in November 19. After rehabilitation, its patient is fine, and 2017, it's absolutely fine. So, question, this is success or failure? When to stop ventilation of lungs? The next cases, 46-year male with intractable epilepsy. She was embolized 6 times in other hospital. You can see this is terrible AVM after irradiation and after 6 embolic procedure, embolization procedure. After radiosurgery, possible C of occlusion of A1 and development of moya-moya vessels. Catheterization of anterior cerebral artery is impossible through the moya-moya vessels. Only one way, it is dural branches and transvenous approach. Now, patient is free of seizure for 10 years with partial arterial embolization of feeders. So we not embolized all feeders. And this picture is unbelievable. Look, before operation and after operation. What happened with microcirculation? What happened with nidus? This is non-standard projection. And right, left side and vertebro-basilar system. The next patient, 30-year-old female with parenchymatous bleeding. DSR show its deep thalamic AVM. It's impossible to treat. With radiosurgery, this is vertebro-basilar system, and you can see lateral and medial choroid artery, 2 small aneurysm, and combined arteriovenous approach. After 1 procedure, malformation is down. Is before and after operation, and carotid system. What happened with microcirculation? I don't close all nidus. Look. Anterior projection and pre- and postoperative result. The next patient was operated 2 times at another institute. He was admitted with intracerebral hemorrhage to our clinic. This is deep AVM, and you see occlusion of sinus rectus. Maybe this cause of bleeding, but bleeding of AVM depend not from size, from draining venous system. This is previous operation result and anterior projection. Left side dominant hemisphere. Combined arteriovenous approach. This venous approach is arterial approach. And result. Patient with symptom, left side, very eloquent area. The next patient, 23-year female with subarachnoid hemorrhage. You see intrahemispherial, very long, diffuse AV malformation with many feeder. It's impossible catheterization, all feeders. This is non-standard projection. Catheterization technique of combined arteriovenous approach and result. So, I think this is incredible. All vessels is normalized without embolization of all feeders. The next 27-year-old female with intractable epilepsy, 7 times operated in other hospital, with radiosurgery. You can see thrombose of sinus rectus, or occlusion of sinus rectus, non-standard projection, and many, many small feeder. A very difficult combined arteriovenous approach, but sinus is closed. And result. Before operation and after operation. This is same deep AVM after operation and deep thalamic AVM left side after operation. So quintessence of the 20 years of my experience. The doctors should work in complete silence and focus only on operation. Don't start embolization of AVM transvenously. The treatment of AVM technically should be simple. Don't use unnecessary devices. Don't do unnecessary manipulation. Don't attempt to embolize high-grade AVM in one procedure. Start occlusion with AV shunt. Stop embolization if you feel the resistance during injection. Begin embolization from a less eloquent area. Don't push an embolic agent quickly. And ask yourself, what I do now? Sorry. So the great discovery, the change in my mind about AVM 20 years ago, the vascular system of the brain normalized completely after focal venous occlusion of AVM without extensive embolization. Transarterial partial embolization of the fistula and nidus is used to reduce the risk of hemorrhage. This is extremely important for the embolization of the eloquent area and deep AVM. Thank you.
Do we control the blood pressure after the vein occlusion? Control the blood pressure? How to control blood pressure?
Control?
Yeah.
I'm sorry, what is control?
Because, you know, I'm doing the open surgery also. So normally after the big AVM resection, we will decrease the blood pressure.
Never.
Never.
We never don't do open operation after occlusion of AVM. Never.
No. I mean, after you occluded the vein part.
Yes,
yeah.
This is very big thema, and I said only small part from this big AVM treatment. We work with pressure monitoring, intranidal pressure monitoring. It's very interesting. We have a wide wire with sensor of the end and possible look changing of pressure after transarterial embolization in venous system. This is only one point, but we have many possibility for prevent of hemorrhage. But we know after occlusion of normal vein, possible hemorrhage. And AVM, it's, yes, possible. And but we know of AVM, it is arteriovenous shunt and changing of bridging venous system. And we don't have ischemic complication after transvenous approach. But this is not normal vein. In normalcy, but I'm neurosurgeon, I'm not radiologist. We know after of coagulation of convexital vein, possible venous infarct. But in the AV malformation situation, it's not happening.
Actually, I have a lot of questions because it is hard to imagine what you are doing. So my understanding is, please correct me if I am wrong, you do transarterial and transvenous. With transarterial, you stop the AV shunt, the direct or high flow shunt, and then maybe decrease nidus by transarterial in few sessions, and in the last session you do transvenous, correct?
Yes.
And in the last session you put transarterial plus transvenous, correct?
But we have many possibilities. I don't propose only transvenous approach. Possible catheterization of venous system and embolization venous system transarterially. In situation of arteriovenous shunt, it's possible. So transvenous possible transarterially, transvenous, but very important, in start of embolization, AVM never not occlude of venous system.
Yeah.
And malformation need of time, but very quick change of hemodynamic after big high-grade AVM and fistulas.
So you stage.
Yes.
By transarterial embolization, and lastly you do transvenous.
But treatment of AVM, this is important for singing doctor. It is not carotid stent. We put it open. It's very important, very, very good analysis of venous system and plan what would you like to do the next step. And in small AVM, possible occlusion with one procedure, but high grade and high fistulas malformation need step, 2-3 steps.
And let's assume that there's not one vein only. For example, you have several veins. In many of the big AVMs, you have more than one venous drainage. So how do you select which vein you are going to attack? Number one. Number two, how do you control your injection from the transvenous side?
We know many possibility of AVM, possible multisectoral AVM, possible with one drainage system, possible many drainage system. So why I said about very good analysis, what would you like to do? Usually, we have one big vein and all other vein, it's peripheral vein, it's not malformation vein. And after occlusion of, this is target of pathological vein for occlusion. This is important. But about this possible write one big book about treatment of AVM, but it is very difficult, many different situations possible. And usually we have one or two big draining vein and other vein, it is normal, only dilated, but it's big pressure in venous system in this shunt.
So you are advocating after decreasing the arterial flow, you occlude the main, so-called main vein without attempting to finish the entire nidus intra-arterial.
Absolutely.
Correct?
Yes, absolutely. Yes,
correct?
absolutely.
My second question is, you said you inject onyx in the venous side and wait for 5-10 minutes, 15 minutes, so that it will solidify and it will create the plug so that the material that you send goes to nidus rather than going all the way to vein, right?
I work with heparin. And I don't see plug in venous system.
No, plug meaning the plug with the onyx, the embolizing agent. You create a plug with the onyx. My question is, at least in our experience, if you wait the microcatheter without injecting any for more than 2 minutes at most, the microcatheter gets blocked. and you cannot send more material.
Yes, this is possible, but onyx have tantal powder. It's possible problem with catheter, but for me very good. I have help embolic material, and this material without tantal powder.
So you do it with the help, not with onyx.
No. All together. I work with all embolic material. It's
Okay.
So it's not that there's like a 5-minute pause, like drinking coffee and then doing. No, it's not that. It's small amounts, very tiny.
Yeah, that's what we do in the transarterial at the beginning.
yes. This depends from situation, but
You see that change, so it's not that there's 5 minutes.
Yeah, that's how we do in our transarterial in the old times to create the plug so that we can send material forward rather than going reflux. So you do the same thing in the venous side, like a little bit of injection weight, little bit of injection weight, correct? Okay.
Can you can I take this blooding system course? Just to bring some water to your opinion. I assure you. You should never forget that he's like
The first one, I know.
the first one
I know very
who spoke about the occlusion of the venous system. He was crucified by the Good Thinking Society. I didn't say any name, but by the Good Thinking Society. For example, belonging to the WFITN. If you need more information, I can give you more information.